For the oration, I'd like to call the chairpersons, Dr. Sukumar Barat, Dr. K.S. Chhajer, Dr. Binay Agarwal, and Dr. Daga on stage. Dr. S.K. Todi. Dr. S.K. Todi, please come on stage. Dr. Lovely Agarwal, please present the bouquet to Dr. Todi. The medal will be presented by Dr. Chhajer and the shawl by Dr. Sukumar Barat. The medal will be presented by Dr. Daga. The bouquet by Dr. Lovely Agarwal. The citation will be read by Dr. Raj.
Dr. Subhash Kumar Todi is widely regarded as one of India's most respected voices in critical care and emergency medicine. With over 30 years of dedicated services, he has significantly saved the field through clinical leadership, academic contributions, and innovative research. He currently holds the position of Director of Critical Care and Emergency Medicine and Head of Academic and Health Research at AMRI Hospital, which is now known as Manipal Hospitals. While also contributing his expertise as Manipal Hospitals, his qualification includes MBBS, MD in Internal Medicine and MRCP UK. A fellow of Indian Society of Critical Care Medicine, Dr. Todi has been instrumental in development of new guidelines related to sepsis, ventilator care, infection control, and antimicrobial stewardship. An acclaimed academician, Dr. Todi has authored over 130 peer-reviewed publications across India and international journals. His research, particularly in glycemic control, ICU-acquired infections, and antibiotic resistance, has been lasting impact on critical care practices. He is also a regular contributor to clinical handbooks and serves an editorial board of key medical journal. His mentorship has guided countless young intensivists and medical research across the country. Dr. Todi has played a key role in global collaborative effort such as International Nosocomial Infection Control Consortium, sharing expertise that has informed ICU safety protocol worldwide. A widely regarded speaker, he frequently presents at leading academic forums and medical conferences, addressing issues ranging from evidence-based ICU management to ethics in critical care. Recognizing Dr. Subhash Todi is to honor a pioneer who has merged excellence in medicine and compassion and academic integrity. His lifelong achievement contributes to raise the standard of critical care in India and inspires the next generation of healthcare professionals. Thank you very much, sir, for all your contributions, and we are very happy and glad and feel grateful to have you here, sir.
Thank you, the scientific committee, Dr. Tantia, who unfortunately couldn't be here, and the chairs. I wish Omji would have given me common successes in ICU, but this is what I am given. So just as Mahesh has talked about leadership, I'm going to talk about the mistakes in ICU. You see, everything started with this monograph from Institute of Medicine, America, which is equivalent to ICMR, what we have in India. To err is human. And that opened the eyes of the world that what is happening in the hospital. But what I would add, not to learn from mistake, not to learn from errors is inhuman. Yes, to err is human. We all do mistakes, but we need to learn from our mistakes. And what do this monograph said, which woke up the world and started the quality movement in the entire healthcare organization. In US, 98,000 people die in any given year by medical errors in the hospital, which is equal to a jumbo jet crashing every day, not an Air India crash once every 25 years. That's more than dying of motor vehicle accidents, breast cancer. And it's a problem with the system. It's not a problem with not a good workforce, but it's a problem with the system. So this is what this document highlighted. So these are some introductory remarks before I go to the mistakes. And the healthcare has been equated to a risk of mountain climbing and bungee jumping. You can imagine the kind of errors or the risks that happens in the hospital every day. Some say this might be an exaggeration, but when you look at the data systematically, it's not surprising. If you go to each and every nursing homes and hospitals and start looking at errors, but that is what opened the eyes of the world. So that is acceptance. Yes, we do make mistake. What about Indian data? Unfortunately, I couldn't find much. There was only one article on this, but this is equivalent. A lot of deaths due to medical errors. So that's one aspect, one introductory remark, that is the magnitude of this problem. The second is our perception. You see, we think we might be doing things right. So this was an old study where it was a survey of German ICUs, random visit of external intensivists, random visit. The doctors in the ICU didn't know, and the ICU directors of perception of things that they were doing correctly. For example, as you know, all ventilated patients should have a tidal volume of 6 cc per kg. When these directors were asked how many of their patients were having 6 cc, 80% raised their hands. But when this intensivist visited their ICU, only 3% were ventilated with 6 cc. So even the directors believed they were doing correctly, but perception and reality is different. When they are asked what is the average sugar in their ICU, is it ideal between 140 to 180? 70% said yes, but only 5% of the sugars were 140 to 180. So that's the second message, is our perception of the things might be we might be thinking something, but if somebody goes and does audits and surveys, you will find the gap. So that is the second message that I would like to give. The third is, you see, the term mistakes or errors is taken as a safety problem, not a quality problem. But they are the same. What is quality? Quality is something should have been done but not done. For example, DVT prophylaxis should have been given but was not given. So it was a quality problem, error of omission. Whereas safety should not have been done but was done. DVT heparin was given to somebody who had a bleeding diathesis. It is an error of commission. Both are errors. One is of commission, we have done something, and this is taken as mistake. But I think even lack of quality is also a mistake. Error of omission is also a mistake. So these two are the same, both sides of the same coin. So both quality and safety. So remember these three things as an introductory remark. One is the magnitude of the problem. Second is perception and reality. And quality and safety are basically the same thing. And this gentleman from Indian origin has done a phenomenal work on this. This checklist manifesto has been the bestseller, How to Maintain Quality. Now coming to meat of my talk, 10 common mistakes in ICU. First and foremost, because I'm also a culprit of the same, because of the busy rounds and all, we fail to examine clinically. And I think that is the first mistake that we do. This was from St. John's Bangalore team. They have published this recently. And I have written a chapter, How to Identify Early as Impending Signs of Organ Failure. The chapter starts with 2 quotes. Early sepsis is difficult to diagnose, but easy to treat. Late sepsis, everybody can diagnose. You see, even the junior most person can diagnose, but very difficult to treat. Organ failure does not happen suddenly. All of a sudden, you find a high creatinine, but it is detected suddenly. He might be having a lowish urine output the previous night. The next day we did a creatinine and we said this patient is in renal failure. So it is detected suddenly, but didn't happen suddenly. It is happening over time. So remember, failure to examine clinically. This is Max Harry Weil in 1969. He is the father of critical care. Even at that time, he said if we examine the toe of a patient, and if the toe is cold, it is almost equal to a low cardiac index. He has shown scientifically, if we measure cardiac output and skin temperature of the toe, it equates. So we don't need, always we have to have sophisticated gadgets of cardiac output, measuring skin temperature. We have to put our hands to the patient's feet. And this is something which should be done by every doctor in the ICU at the first when they confront the patient, is the capillary refill time. We do it every day in all the patients to see whether if you press the index finger, how long does it take for the color to come back? It should be less than 3 seconds. And a very big study had shown this is even better than lactate. So you see, they have shown it, if a capillary refill time is prolonged, it is as good as having a high lactate. So there is no excuse of saying that I don't have a lactate. This is a shock state if your capillary refill time is increased. So it's very important one should get tuned to how to measure capillary refill time and practice, because these seconds, 2 seconds, 3 seconds, 4 seconds, so one has to teach themselves and train themselves how to do this. So that's second very important clinical examination. This modified early warning score, very important. And so this is a mu score which tells you early, just by vital signs, which is an extension of physical exam, that this patient is not doing well. This is a screenshot I took yesterday from the EMR of our hospital, electronic medical record. It comes, you see, every few hours, the mu score automatically is shown in the chart, in the EMR, because they have all the vital signs. So the vital signs and the EMR records the mu score almost every 3 to 4 hours. So very versatile, and it is there in the nurses in the screenshot. So it's very important, this mu score. Then comes the Q SOFA. Some of you might have heard of Q SOFA, a quick SOFA, which detects, it's a prognostic feature, hypotension. Glasgow patient is little confused, little delirious, hypotension and respiratory rate of 22. You might be wondering from where this number of 22 came. You see, Marvin Singer is the one who designed this Q SOFA. I asked him that why respiratory rate of 22? What is the data of 22? Where did you come from this number? He said, if you go to any hospital, by default, all the nurses write 20 as the respiratory rate. When I went back to my ICU and I looked at the chart, it was 20 respiratory rate. So he said, In order that the people count respiratory rate, we have made it 22. There is no scientific reason behind 22. If you go back to your hospitals, look at respiratory rate, you will find it's 20, written there. So it's very important. Respiratory rate, one of the most sensitive way to detect early or impending, not only respiratory, but organ dysfunction or acidosis. These are shock index. One can calculate systolic. You see, blood pressure has to be correlated with heart rate. Just don't go by blood pressure. Somebody having a bradycardia might be having a low blood pressure. That's normal. So whereas a tachycardia and a normal blood pressure might be abnormal. So it's very important we have to have the shock index in mind. And in sepsis, it's the diastolic blood pressure, which is very important. So we should look at the diastolic blood pressure, look at diastolic shock index. So these are the clinical examination and extension of clinical examination that tells us what it gives us a window of finding impending organ dysfunction, impending sepsis. Second is, as you are all aware of, we are facing an epidemic of multi-drug resistant infection. And one of the reasons is optimizing antibiotic. First is the time. This is from Surviving Sepsis campaign. We all agree if shock is present, it has to be given antibiotic within an hour. If you do an audit, you might find it is not done. We have done in our hospital and we have found it, we are okay. We are giving it within an hour, but the most important is the lower right corner. 3 hours, if we are not sure that there is an infection, patient is not in shock, you don't have to give very broad spectrum antibiotic immediately. Do a malaria, do a dengue test, and if it comes out of that, we don't need antibiotics. So wait, don't give broad spectrum antibiotic. It might be something different. It's very important. The second is the dose. You see, we all decrease dose if there is renal dysfunction. Increase creatinine, we decrease dose. We forget about this. In a patient who is young, has given lot of fluid, there might be a high renal clearance. Recently, I had a young person with pyelonephritis. The fever was not coming down with 1 gram thrice daily of meropenem. And he was making good urine output and good creatinine. We increased it to 2 gram TDS and he responded. So remember, a young patient having a good urine output, having a creatinine and urea which is normal or even slightly normal. And this patient probably has increased GFR. We don't calculate GFR. All our GFR calculation is for low GFR. So large volume resuscitation do give a high antibiotic and higher dose of antibiotic if it is safe in that patient. Short course, the duration of antibiotic. There are many examples now. This was an intra-abdominal infection where source was controlled. Appendicitis, cholecystitis, operated 4 days. 4 days of antibiotic is good enough in these patients. NEJM article. 7 days of antibiotic for gram-negative bacteremia are very important. It favors short treatment. Or we can do a CRP-guided antibiotic stoppage. If the CRP comes down by 75% of the original, even if a patient has some fever, slightly high white count, stop antibiotic. The maximum kill of bacteria is in the first 24 to 48 hours, 90%. And after that, the kill is around 2 to 3% every day. So it's only 4 days might be good enough for peritonitis if the source is controlled. You can see so many studies, 3 days, 5 days, 7 days is as good as 10 days, 14 days, no difference. So it is always worthwhile to give shorter courses of antibiotic. What about de-escalation? Can we stop antibiotic? We have to use one of these rapid diagnostic tools. And these are the nasopharyngeal swab, the respiratory panel. It gives us this within 6 hours. Within 6 hours, we know which bacteria, which resistant organism are we dealing with. Meningitis, CSF, gastrointestinal panel will soon be having a urinary panel as well, once the blood culture positive. So don't wait for the culture, for the other things. Just look at the swabs and de-escalate antibiotics. If it is influenza, just don't give antibiotic. We always say there might be some secondary infection. How many patients? Very few will have secondary infection. So I think it's very important. We need to optimize antibiotics. Giving too much of oxygen. Now, sometimes we aim for a higher saturation. This was a study done, 90%, keep 90 to 92% saturation. There might be even harm by giving more oxygen. So don't try to raise saturation levels in ICU, that many of the studies have shown. This is one of the big studies, 90 is as good at 97, 94. Probability of survival was better with 94. The reason is we create oxygen-free radicals. And we don't improve in oxygen delivery so much by decreasing saturation by 3-4%. So it's very important, keep this in mind. Fourth, we are going to have a talk by Dr. Sanjay on fluid balance. The only couple of slides on this. The last part of it, the hypervolemia, the de-escalation part. Once the acute part is over, we need to get rid of this extra fluid. Either patient gets rid of it himself or herself, or we give diuretics or some other ultrafiltration. So de-escalation is very important. Don't let the patient to be volume overloaded. Too much of sedation, we give too much of sedation. And I think that is one of the biggest problems, increases ICU length of stay, ICU complication, even ventilated patient, it is said time to stay awake. And the way to do that is very judiciously following a sedation scale. Like we have in our nursing chart, if you look on the right side, there is a sedation scale. If there is a goal, you have to say, I want this patient to be 3, that is calm and oriented. And every hour, the nurse has to decrease the sedation till it comes to 3, or increase the sedation if the patient is agitated. So it's very, very judicious. We do audit of this practice, and we have found it's not followed in 50% of the time. But this is the only way we achieve the goal of sedation we want. So again, you know, the safety, the quality part comes here. Enteral feed. Should we be giving full enteral feed? It is a practice. The sicker the patient is, the more malnourished the patient is, we give a high enteral feed initially. The problem with critical illness is there is a lot of catabolism. There is muscle breakdown, there is fat breakdown. So body makes a lot of calories and lot of protein breakdown amino acids. And if we are feeding full energy from outside, it is hypercaloric feed, which is not good for the patient. So there is a tendency not to give too much of feed. Permissive underfeeding or trophic feeding. Start slow. Go to an early full feeding only late and on 5th day or 6th day. So permissive underfeeding was better than early full feeding. 7th, avoid early parenteral nutrition. I have seen few patients, if they are not eating, they are not able to give enteral, you start early parenteral. This was a landmark study where they waited till 8 days. Even if a patient is not eating, you are not able to give enteral feed, giving early parenteral nutrition is harmful. If 7th, 8th day you are not able to give calorie and protein, you start parenteral nutrition. Then comes the sugar control. In diabetics, we all know in non-diabetics, it has to be 140/180. But what about diabetics? What should be the sugar control in diabetics in ICU? They have found that glucose of 270 there was no mortality risk. If a person who is a diabetic had a high HbA1c, and if we target 140 to 180, the patient comes to harm. So the current practice is look at the patient's HbA1c, see what is the patient's approximate average sugar would be, and try to keep that. So we always look at if it is HbA1c of 8 or 8.5 or 9, you try to keep it around 200. Don't make it 140 to 180. Most of the studies point towards this. So not a very tight glucose control in diabetics. There are two controversial mistakes or kind of comments I would make. You see, one of our, the founding father of critical care in India, Dr. Farooq Udwadia from Mumbai said the term intensivist is not very correct, as if we are very intensive, do very intensive procedures, do intensive things, which might not be good for all patients. This was a study done by Professor Mitchell Levy. He was the president of Society of Critical Care Medicine in America, the APEX Society. He wanted to show if ICUs are run by critical care physicians, the outcome is better. So he looked at 123 ICUs, 100,000 patients, and collected all the data of the outcome. And he had sleepless nights by the results. I had spoken to him, he said, but I have to be honest. He's a Buddhist, actually. He's a disciple of Dalai Lama. He said, I have to be honest. I have to publish what I have got, even if I am president of Society of Critical Care Medicine. They found that ICU run by a critical care physician have a higher mortality. Why is that? Everybody was, no, you see, this was published in Annals of Internal Medicine. No critical care journal accepted this. Annals of Internal Medicine is a good journal, so the methodology was not flawed. So why is that? What they found, if a less sick patient gets admitted in the ICU, they get a lot of procedures which may be harmful. So another message would be admit patient in ICU who really needs intensive care. And definitely critical care physicians are good in maintaining very sick patient, managing very sick patients. But less sick patient, we might be overtly aggressive and might be harmful. So that is another subtle message. And lastly, as I said, quality and safety are the same. Now, how do I identify? I say my ICU is good, then the other ICU. How do we identify a high quality ICU? You see, SMR is mortality, how many patients are dying, and economic is what is the cost of their care. The lower left is the best. Low cost, low mortality. I want my ICU to be in the lower left corner. So how do we identify? This was a study done many years back where they looked at the practices of an ICU which differentiates better ICU than a not better ICU. Now, there are three pillars of quality, as you all know: structure, and process, and outcome. Now, what is structure? Structure is what we have. How many doctors, how many nurses, whether we have good space, whether we have good machines, and all that. Process is what we do. Are we practicing evidence-based medicine? Are we doing things correctly? And outcome is what is the mortalities, length of stay, and others. So which one do you think will affect outcome? Is it the structure or the process? How many you think is the structure? Raise your hands. How many think process? Everybody will think process. Everybody, but what they were surprised, it was neither the structure nor the processes which differentiate a good from a not so good ICU. But it was the culture of the ICU, as Dr. Mahesh mentioned, it was the nursing leadership. Nothing, you might have a very good organization having good quality, but if there is no communication, the culture is not there, and there is a conflict going on, the outcomes are not good. So that's what they found. They also looked at these aspects of the ICU. That was also an eye-opener. So this is another, probably an error. We need a collegial ICU environment to have the best performance. So areas for improvement, to summarize: clinical examination, antibiotics, fluid, oxygen, glucose control, enteral feed, parenteral feed, sedation. So these are the things that we need to look at. And the final message is, as we gone through all this, less is more at the end. Less oxygen, less glucose, less procedures. So less is more in ICU. Thank you very much for your patient listening.
Hello. Thank you, Dr. Todi, for this enlightening deliberation of yours. We have learned many things that we do not practice in our day-to-day practice. And now it is open to question and answer.
Can I ask? Can make me. Subhash, this is Mahesh from this side. It was a pleasure listening to you. I did not get a chance for so many years. Those who don't know, Subhash and me, we belong to the same batch from different medical colleges. It's really a great oration which you delivered just now, a lot of take-home messages for all of us. Just one or two comments. One about sedation, which you talked about. Do you practice patient-controlled analgesia? And if you practice patient-controlled analgesia, how do you entitle that those stages are maintained? Because they would possibly have their own agenda when they are doing the patient-controlled analgesia. Second issue which you did not mention, possibly because of the time, is hemoglobin level. So particularly when you talk of a gastro-ITU, I think we over-transfuse also. So that's another point which we need to know, that we do not want a hemoglobin of 11 or 12. We are happy with a hemoglobin of 8 to 9, except in a subset of patients with ischemic heart disease. So I think these are some of the additional points which I thought you can address. Now, when you talked about these problems, you are talking for of overall ICU. But are there problems which are specific for a specialized ICU? A cardiac ICU and a nephrology ICU. Now we have ICUs which are specialty oriented.
Yeah, thanks, Mahesh. You know, hemoglobin, there are many other things which were not covered. Hemoglobin, yes, we should not over-transfuse. But the most important things overall is we need to look at our practices. Every month, we need to see how many patients in my ICU had a blood transfusion with a hemoglobin of more than 7, who was not actively bleeding and was not hemodynamically unstable. Then and then only I would know whether my practices are correct or not. You'll be surprised if you do that, almost 30% every month we find. And then don't stop at that. The next is, why did they get that blood transfusion above 7? Unless we know that, we won't be able to close the loop, because there is no point having that number, 30%. So it's always important, have a look why. Many of them were post-operative, had surgeons' advice to give, and many other things. So then you have to talk to the surgeons and the other things. So yes, quite right. As regard the specialized ICU, you see the general principles still remain the same. The core principles, wherever you go, in whatever ICUs you go, the physiology, the human physiology will be the same. Whatever organ, yes, the nurses get trained into one particular organ system. So overall, it might be a better care. But I believe the general principles should remain the same. In ICU, the patient-controlled sedation, you know, analgesia will be a little difficult because many of them are on ventilator. We want to have a goal and we need to titrate the goal. So apart from perioperative, the patient-controlled analgesias, except probably in pancreatitis and all, are not practiced so much. So thanks for your comments.
Thanks a lot, Subhash sir. It's always a privilege and learning your each presentation and each appearance.